Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 63 of the OBGYN podcast. Today is the monthly checkup for September 2019, and to help me get through today's topics, I have Dr. Vai Umesh and Dr. Sara Kim with me. Welcome back.
Hello. Hi, nice to be back.
So it's been a long time since we have done one of these, and I think that now that the summer crazy season is over, we'll hopefully be getting back into form. Again, I want to thank Cooper Surgical for their support of the show, and also to the Patreon supporters who keep the show going. So thank you. Today, I think we have three great topics, and so since it's been so long since we've done this, I'm excited to dive in. The first one is a paper that came out in PLOS. It's actually a while ago. Showed you how long ago that we were trying to put this together. But it came out in July of 2019, and it's entitled Risks of Stillbirth and Neonatal Death with Advancing Gestation at Term, a Systematic Review and Meta-Analysis of Cohort Studies of 15 Million Pregnancies. Phew. Right? So... big title. What they did is they looked at all these, ended up being 12 studies, 9 million pregnancies between 1990 and 2018, and they looked at the risk of stillbirth by gestational week. To sum up their findings, and we're not going to dive deep into the paper, they found the risk of stillbirth to be ranged from 0.1 per thousand to 3.18 per thousand from 37 weeks to 42 weeks. And I think what the meat of the study is they found that for every pregnancy that progresses past 40 weeks into 41 weeks, there is one stillbirth for every 1,500 pregnancies. And then the second part of the study, they looked at neonatal mortality to say, if we deliver earlier, is there an increased risk of neonatal mortality? And they found the answer to that was basically no. There's a little variation from week to week, but it's pretty flat. I do want to mention two things about this paper, even though I said I wasn't going to talk about it much. We all see more of these systematic analysis or meta-analysis coming out. This particular paper has some really good graphs in it. It's actually figure 2, where it talks about all the different kinds of issues with the different studies. It's just a very nice graphical representation for how they did it. So if any of you listeners are out there interested in how to represent data, they did a pretty good job in this one. So anyways, what is interesting to me about this, first is it's such a wide range they chose from 1990 to 2018. And we have talked in the past on journal clubs about how, the more people you include, the more generalizable it is. But also, sometimes it's hard to find your, exact findings in there. What this one suffers from, I think, is there's been a wide change or a big difference in how we treat or monitor women during pregnancy in the 30 years that were studied here. And so it's hard for me to say, using the techniques that we do now for fetal monitoring, in fact, in the U.S., where everyone probably gets over-monitored, is that number from 0.1 to 3.18, is that still true? And the answer is I don't know, but it makes me kind of worried about the study. But let's take it on face value. And I swear I'm going to ask you guys what you think in a second, this is another paper in this kind of march towards wanting us to induce everybody at 39 weeks or 40 weeks. So I guess I'll start out with, when you read this paper, what were your thoughts on it? And, what did you think that this fits with the literature that's been coming out recently? Sarah, I'll start with you.
So I was a little surprised, actually, when I'm reading this about the high rate of, stillbirth after 41 weeks. I think that kind of hit me hard. And the first question I thought about is, what is the rate of stillbirth after 41 weeks in the U.S.? And that was something that I thought about, and I didn't look it up, but that's something that I was like, oh, is it as high as in the UK? And is the rate kind of like what you were saying, as high because maybe it spans such a long period of time versus more recent, based on, the changes that we have made. I have mixed feelings about this study because I think I started thinking about if a patient were to read this paper, would they come to me running for an induction after 40 weeks? Because if on an individual level, it's very scary to say, okay, I'm now 40 weeks. You're telling me at 41 weeks, the rate almost it goes from 0.11 over 1,000 to 3.18. That's a huge difference. I will want to discuss with the provider, hey, I want to be induced after 40 weeks. I think that's kind of what I was looking at when I was looking at this paper. But I don't really know for sure what is considered low risk pregnancy, when they talk about that, and how I would group my patients into what category, and how to really counsel the patients in a way to make them understand that there are also risks of inducing. Induction is just not without its own risks as well. I think those are like the little kind of questions that I had, generally speaking, about this paper.
Okay. I think some good points in there we can talk about in a second. Vi, what do you think?
Just to kind of go off of what Sarah just mentioned, they talk about how they routinely, they say these patients get routine antenatal testing and weekly blood pressure checks and things like that. But I wonder, is their testing similar to what we're doing? So obviously my frame of reference is what we do in our practice at Stony Brook. And I know routinely whether these patients are seen in clinic or in triage, after 40 weeks, they get a BPP. More often than not when they get any kind of ultrasound surveillance. So by doing that, are we essentially protecting our patient population and kind of monitoring enough to say by pushing the induction date to 41 weeks or so, we aren't in the same category as this group where maybe they aren't doing the same kind of surveillance. So maybe teasing out those differences may provide some sort of an answer as to a potential difference in the rate of stillbirth between the two populations. And the other thing, honestly, is how it changes our practice guidelines. I know quite often we do induce at 41 weeks. So is this telling me that I should be more vigilant about making sure the induction happens like at 40 and 6 so that by 41 weeks they're delivered? Or is that, getting too specific about the exact date? So I was trying to think about how I would do anything differently than what we're already doing.
Yeah, I mean, this paper... The trend that this paper shows is no different than we've known for a long time. And I think what Sarah was saying is that the magnitude that this paper shows is different. Usually, what we were taught was between 39, 40, up to 41, the rate of stillbirth does increase, but it's not a lot. And then after 42 weeks is when it really starts to increase. Let me rephrase. At 42 and 0 and beyond, it starts to increase, right? It's hard to be clear here because when we're saying 41 weeks, we're saying 41 and 0 to 41 and 6, right?
Right.
I think, Vi, you raise a good point, and this is an argument that I have routinely in our practice, is that there's no data between 41 and 0 and 41 and 5. Right. And this paper doesn't give that either. This is not granular enough to tell us that. It just says in that week, this is a stillbirth rate. And so we see it all the time. Everyone gets induced at 41 and 0 on the dot, right? And I have railed against that for a while, and maybe I'm wrong. Maybe we should be inducing people that 41 and 0. But I like this. I like this paper, even though I disagree with the number. It's nice to have a number. And so say 1 in 1,500. All right. Well, then I can still use that number and I can start looking at other things. Okay. Well, what are the consequences of inducing at 39 weeks or 40 weeks? What is the increased risk of section? What is the, neonatal? They talk about mortality in this paper, but they don't talk about morbidity at all, right? Probably because they don't have the data. So I'm not faulting the paper, but they don't talk about the HIE or, GBS sepsis or what else goes into that, right? And so I think and the answer there is, we don't really know what the difference is, but maybe there is. But when we start getting concrete numbers, we can really start comparing apples to apples as opposed to apples to, fantasy fruit, because we don't even know. But, going back to what you said, Sarah, the ARRIVE study tells us now that we should induce at 39 weeks because there's no difference in C-section rate. Now, that's one study, and one thing I hate about obstetrics with the bloody fiery passion is that everyone sees one study and decides to change their entire practice.
Right.
And I think the cooler heads are mostly prevailing here, and we have not adopted mass induction at 39 weeks, but a lot of people were advocating for it when that came out. But hopefully we'll have another 1 or 2 studies to see if that finding holds up. But even if it does, what effect does that have on our unit? Right? If we're suddenly inducing every single patient at 39 weeks, how many inductions is that? How long? How many hours is that? How many nursing hours, doctor's hours, anesthesia hours? Right? Can we as a medical system support that? And that's a question that some smart people have asked, but no one has really answered yet.
Yeah, absolutely. Just to add to that, I mean, we know in the last couple of weeks just on L&D, we didn't have enough labor rooms because they were full of elective, I don't want to call it elective, but essentially inductions at 39 weeks, sometimes with reason, sometimes without, but oftentimes elective. And then when patients were sent in for real reasons for delivery, we were having trouble accommodating them. And that's sort of a very difficult situation to be in.
Right. I mean, labor and delivery buildings are built with a certain, numbers involved in that, like how many laborers and whatnot. They do not, like, how many hours does each woman spend in a labor room, right? Like, smart people do this math. There's actually a good paper from the military I can send you that actually it has a formula for how many labor rooms you need for what population, right? But that's all predicated on the fact that a significant number of those women are going to go into labor, right?
Yeah.
If you start inducing everyone, those numbers are all off.
Right.
But at the same time, and I sometimes find that 39 weeks, between that 39 and 40 weeks, even the smallest indication kind of makes us lean towards induction. Because kind of what you were talking before, like populations versus individual, it's harder to tell a patient who comes in with like small worry to say, actually, it's fine, you could go up to 40 weeks, versus when they're like, well, I'm already term, why can't you just induce me? I have this small little problem, which may not be what we call like a legit indication, but sometimes I feel like we do kind of try to fish for a reason if they are 39 weeks. Because of studies like these, I think, kind of makes you also kind of say, well, I guess there's no real mortality from inducing neonatal mortality. I guess we could, especially if the patient wants it. I guess I don't want to wait until 41 weeks to see what happens. So then you kind of lean towards inducing.
Right. Yeah. I agree with that. And I think that, the people come in, if they say I had decreased fetal movement, that's it.
Right.
Right. Even the BPP is 8 out of 8.
Fluid, another common one.
Right?
Yeah.
Oh, decreased fetal movement, 39 and 2, that's it. Okay, we're inducing you, right? Because we don't want to take any risks.
Right.
And some of that is, just, tort reform or lack of tort reform. And part of that is patient satisfaction and their worry.
Right.
But when we're counseling these women, and, I talked a little bit in the last few months, has been months, but about informed consent, and I'm going to talk about it more, hopefully in the next few months, is how do we really inform these women of the risks, right? Because I can tell them the stillbirth risk, but the other risks aren't as well known or as well categorized like this. So I think it's a difficult conversation to have. And of course, most of these moms are going to say, well, I don't care what the risk is to me. Right. But then they spend 36 hours or 40 hours in labor, and then they're all pissed off, and then they want a section because they've been there so long.
Right.
So I don't know. It's a tough one. And as you were saying, Sarah, there is this kind of natural push and pull or conflict between population health and individual health, right? Like what's good for one woman, for that particular woman, if you apply it to every woman, isn't necessarily a good thing.
Right.
Every single woman may benefit by being induced at 39 weeks individually, but as a whole, it'll destroy our healthcare system. Right. So how do we balance that as doctors? Because we're only taking care of one woman, right? The person in front of us, but yet we are somehow responsible in aggregate for an entire healthcare system. Right. So I'm not sure what the right answer. We have this issue with TOLACs. We have this issue for maybe GYN surgery. We'll talk about that in a minute. So I don't know. Like, where do you guys see your role? Like, do you feel this kind of natural tension as well, or are you just more focused on the person in front of you?
I think that you see some of it as residents when you deal with private patients versus staff patients, and specifically resident clinic patients versus probably staff patients, attending patients. And I mean, it's just a small example, but I do think as residents in our continuity clinic, because we don't necessarily have a long-term relationship with one particular patient, and you do see different people every time in your clinic, you tend to take a little bit more of almost I don't want to say depersonalized, but you kind of take a step back and you tend to view people more objectively, and you're less biased by individual things and the nuances in their anxiety or their care, that sort of thing. But I do find that people who see the same practitioner for a long period of time, those practitioners are the ones that are more vigilant about noticing small changes in the clinical status of a patient and may perhaps practice more on an individual basis than as a population basis.
Yeah, I agree with that. And it's not something wrong with that, Vi. We mentioned this when we were talking about termination a few months ago, that once you hear someone's personal story and, you get involved in that, it's very hard to look outside that individual picture, right?
Right.
But when you don't really know the person, it's very easy to make a judgment. It's very easy. I mean, it's just human nature. So.
Right.
Exactly. Right.
Yeah, I find it, I do think it's much easier as a resident to be more objective, I think, in that sense, because you're like, okay, well, the evidence says this, I'm just going to say that. And because you don't have that, that connection or that relationship that you built over the 9 months with that patient, it's much easier to, I think, say no. Yeah. Agree.
Yeah, I mean, I'll tell you in private practice, you're also worried about pissing the patients off because they're going to go tell all their friends that, my doctor sucks, don't go there, and then, you're going to go out of business. Right. And it's funny, we run into this all the time. It's getting better now, but with pap smears all the time, right? How many conversations I had about, you had a pap smear last year or 2 years ago or now 4 years ago, and you don't need a pap smear this year. Well, I want a pap smear.
Right.
Okay, well, you don't need one. Yeah, well, I want one.
Okay.
Right? And how long are you going to have that conversation back and forth before you just do the pap smear, right? Right. So, I don't know. You're like, my doctor doesn't even care about my cervix. You want to get cervical cancer, right? So I don't know, but there's this push and pull there. So I don't know. I think that this is a nice foundation for being able to talk to our patients about that risk of stillbirth. And I mean, 1 in 1,500 is actually quite small, anyway. But of course, if you're that 1 in 1,500, you don't think it's such a small chance, right?
Right.
Which again is population versus individual, but it's got me thinking more, and I think we're going to see more of these papers in the next probably 5 years come out, and hopefully when we get some more data, we'll start coming to a consensus as a college about what the right thing to do for these women is. But I don't know, I still don't believe the ARRIVE trial that it didn't increase section rate. I find that very hard to believe.
I found that hard to believe.
Yeah, I've been wrong before, so. All right. Anything else on that one? Any other thoughts before we move on?
No, I think I'm good.
Yeah.
Okay. So moving on to the second, it's another paper. This one is from the Green Journal. This was back in May. This was health-related quality of life with ulipristal acetate for treatment of uterine leiomyomas. Randomized controlled trial. Like I said, it was published in the Green Journal. This was looking at Ella, which is really a emergency contraception, progesterone, agonist, antagonist, which is used to control fibroid size, kind of like Lupron or something, but without some of those side effects. And this actually is pooled data between two of the level 3 studies into its safety and efficacy. And what they did is they looked at placebo versus 5 milligrams versus 10 milligrams in 12-week cycles. They included women 18 to 50 with cyclic AUB, menorrhagia, and fibroids. So again, I kind of like that inclusion criteria, which makes sense for a safety trial. Usually they're very controlled about who you can enroll. But these are certainly the women that we see. They have fibroids, they have menorrhagia, and they're 18 to 50, which makes sense. And what they found was that, it worked, essentially. It had a significant reduction in their had a significant improvement in their quality of life, let me say, and also had some other, good things that it did for these women, which we don't need to go into. And if you all want to go read the study, you can. It's a good study, and we actually might do it for Journal Club someday because it's pretty good. But what this study got me thinking about is, when I started residency, which is getting further and further away, unfortunately, Mirena was really just starting to be used aggressively, and Lupron was relatively new. And so women still, basically, if you had a large fibroid or a fibroid and you had bleeding, you were getting a hysterectomy. Now, a lot of those were still open. They weren't laparoscopic so much, or they were vaginal, but there were a lot of hysterectomies. And as I've gone through the last 13, 14 years now, we use a lot of more Mirenas. We use Lupron. There's now oral Lupron or Lissa, which seems to be working very, very well. I know Dr. Blaber has been on the show a few times using it a lot for both fibroids and endometriosis, and it seems to be working very well. And now there's Ella. So I guess my question on this one is, what effect have you guys seen in your 3 to 5 years of training about these these medications, medical therapies on the treatment of fibroids and menorrhagia on your surgical volume, and where do you think this is going to lead our profession? I'll start with Vi.
So, unfortunately, my sample size is less than that of Sarah's, so this will be interesting to see if we have different perspectives here. But the few times that I've seen this, I find that medical therapies usually inevitably end up leading to surgery down the line. So what I have noticed is the medical therapies are especially useful for women who really shouldn't be getting surgery, especially in the rising epidemic, given the increase in obesity, diabetes. We've noticed so many detrimental effects of surgery and the post-op complications that avoiding surgery in these women that otherwise would not have been possible is now possible by having an alternate therapy. But the other side of this is sometimes these therapies are not sustainable long-term, are very expensive. A lot of the patients that we see are Medicaid patients, and the amount of loophole and the amount of obstacles we have to cross to get prior authorization for these meds is ridiculous. And so in that context, I find that a lot of women come either maybe reluctantly wanting to try something that's not definitive, but eventually ending up getting the hysterectomy. So I don't know that I've seen a huge change, but then again, as I said, I've really only seen this for the period of the last 3 years.
Mm-hmm.
Fair enough.
Yeah.
I think, I really rephrase what I was saying earlier, I suppose. The biggest group of women who have stopped getting hysterectomies are actually the women without fibroids, really. It's the women with the dysfunctional uterine bleeding who for a long time were getting ablations, although ablation is kind of going out of style as well now. And that really, I guess, is where most of it was. Some of it was in the fibroids, but the big fibroid patients were still getting surgery. Mm-hmm. Go ahead, Sarah.
Yeah, I mean, I think generally speaking, I don't think I saw it immediately during my time as a resident, but I feel like I felt it starting from intern year of seeing my chief struggling getting the hysterectomy numbers, getting the abdominal hysterectomy. You started out with getting the abdominal hysterectomy numbers. It was like almost impossible. A lot of the chiefs were struggling to kind of get that. And that definitely shows that, yes, our times have changed where now open surgery is coming out of favor. Hysterectomies in general, obviously the numbers are lower, so they were struggling to find those numbers. And then my year was a year that they changed that to even now make it, so I guess they caught up of doing more minimally invasive hysterectomies, and they kind of doubled the number for that, and the abdominal hysterectomies number went down. So in some ways it was good to see that change, that they were the requirements to graduate kind of caught up with what was happening in the field itself. But even with the change, we felt that even getting hysterectomy numbers, even minimally invasive, was difficult for our class. We got it, but we all struggled to get that number, right. Which goes to show that even though ideally we would all like to graduate with X amount of hysterectomies, it's difficult to do so because just the number of hysterectomies in general have gone down. And that's kind of what I felt as I was graduating is when I'm counseling patients, a lot of them, even for fibroids, initially start out saying, okay, what are my options? And they usually do say, okay, let's start with step 1 first. And I think as residents, how we view conservative medical management may be a little bit skewed because I do agree a lot of our patients come back saying, oh, it didn't work. But I think there is also a compliance factor in that. Some of them are not compliant. They don't really try for a long time and they just kind of come in and say, well, my life is too busy. I have 3 jobs that I'm running. I would rather just get this thing done and over with. I think that's kind of what we see maybe as residents. But when you see in other sometimes in private practices, I've talked to private attendings and say, yeah, I don't do a lot of HIS because a lot of our patients, they come back, they love the medication, they say it helped with their bleeding and they're okay with it. And I'm not sure there's also a compliance factor in that, but I think generally speaking, a lot of them, patients initially do like to start out with more, if it is available and you tell them there is a medical management available, they do try to go with that first and kind of try to avoid surgery if possible. And I do think there's also a factor of sometimes surgeons kind of being pictured as the big bad surgeon coming in to just, cut into me and get this thing out versus trying to help me as a doctor with my problems. And I think there's that view where surgery is kind of viewed as, oh, there's that surgeon jumping into surgery. So I think we're also trained to not necessarily surgery be the first thing we offer. We always are kind of, even though we think maybe surgery is what they need the most, so we kind of are in some ways taught to offer all these other medical managements first to some degree, which is frustrating to some patients who come in saying, I want surgery. And you're kind of like, whoa, actually, let's try all this medical management first, because we're kind of taught to do that, which also has its pluses and minuses, I think, in, our field, generally speaking.
Yeah, I mean, I'll tell you, the insurance companies oftentimes will not pay for hysterectomy until you've tried the medical therapies anyway. So a couple points there. One is, you don't need the number of cases to graduate. The program needs a number of cases to stay accredited.
Oh, okay.
You get to graduate no matter what.
All right.
All right. But the program may not be accredited.
I thought I had to get all those numbers to graduate.
No. But if you don't get your numbers, VI may not be able to graduate from an accredited residency program. So there's downstream effects.
Oh, phew, I just did you a favor.
And the second is, I think, the part of the issue in the resident clinic population especially, and it really hits the self-pay patients more than anybody else, is that there is no assistance to them to purchase medication, but they can get assistance to the hospital to have surgery. And so many times surgery is the better option for them financially, if other issues. But going back to what Vi was saying about the medication versus surgery, medication, long-term medication does cost money, especially anything that's new. I mean, Orilissa is extremely expensive. So you have to factor in if you're going to take that for 10 years before you go through menopause, okay, well, what is the lifetime cost of the medication for you versus what is the lifetime cost of having surgery? Okay, fine. Surgery's probably, at least with Orilissa, going to end up being cheaper than 10 years of Orilissa. But what if you have a complication? What if you what if you have a ureteral injury and you need 3 or 4 more surgeries? You may need to the hospital 3 or 4 times. Right. Now, that individual person may not end up bearing all that cost, because if they have insurance, once they get through the deductible, it'll be covered. But we, as a healthcare system, here we go, get back to population health, are bearing that cost. Right. So, I don't know. And again, we don't have enough numbers there to really be able to compare those things in a meaningful way. Although hopefully some smart person is listening and we'll try to do that. Because I think there's an interesting study actually to be done there, comparing lifelong medical treatment versus surgical treatment. Yeah. The hard part is getting the numbers. All right, maybe we'll do that. We don't need a smart person. We could do that.
I was going to say we could do that.
So then the other thing, so going back to how much, I mean, the data shows it out, bears it out. ACOG has published this, that the number of hysterectomies is going down every single year, right? Depending on where you are in the country, that may be decreased abdominal, decreased vaginal, decreased laparoscopic. Although I do want to say to you guys, we practice in a suburban location that is surrounded by OBGYNs. And so our program does have relatively low numbers compared to the rest of the country. And likely that's because we have a lot of competition. If you go to another program that is, the only, place in town, their numbers are going to be higher just because, they're even though their catchment area may be similar, the saturation with OBGYNs is not as similar. Right. So that is something to consider. That's the perils of training in the Northeast. So anyway, what do you think this does to, so you guys, Vi, you're going to be a 4th year soon. Ish. And Sara, you just graduated. So, you look at your training and you say, okay, are you comfortable doing, laparoscopic, robotic surgery, whatever it may be? And do you think that there has to be a change in our training to accommodate this decrease in hysterectomies? What do you think, Sara? I guess because you already graduated, you can go first.
I think I would say generally speaking, I feel pretty comfortable up to a point. Like I could probably do like the simple ones, like a simple abdominal hysterectomy, the TVHs, not like the significant prolapse one, but like the regular TV. There was a little bit of discensus who'd had vaginal deliveries.
So the people who don't need them.
Right, exactly. But maybe they have like adeno, right? But the minimally invasive approach is they have a small uterus with adenomyosis, with heavy bleeding, and they want it out. Then I probably would do a TVH. TLH, I would say those basic ones I could do to a point, but I would say for most of them, I will probably want I would feel more comfortable if I knew I had a couple under my belt with someone like supervising me, maybe. And that could just be me. And I think I could go in and start the case and kind of do it, but I will feel more comfortable if there was someone supervising me for a couple of them just to kind of see and get my feet wet as like as an attending.
Sure.
Just you know, because I don't think that a lot of, maybe a third of the cases that you log, you're not doing like 90% of the case. You're not doing everything. So there's only certain parts that you're doing. And I think to do something from start to finish as an attending will be very different versus me just doing that as a resident. So I think I would want a little bit more supervision even after graduating with, you know, the required numbers.
Yeah, I think there's something there. You know, even if you do 90% of the case as a resident, you not being responsible and not, you know, having to have that anxiety of you're responsible for the case and thinking through it all. Right. There's a difference there.
Yes.
Even if you're doing technically most of the surgery, right. Most of surgery, 50% of surgery is not technical. It's mental. Right. It's about choosing the patient. It's about choosing the approach. It's about where you put your ports. It's about, you know, your approach, all that kind of stuff. Right. And then the other 50% is actually
doing it.
You know, doing the surgery and having the skills to do it correctly. And actually, I will say 40%. The last 10% is knowing how to deal with complications.
Right. Yeah. So I think I think our program is pretty good. That I would say I graduated feeling pretty comfortable, and I could probably walk somewhat, you know, do a case with a resident, you know, the easy benign, you know, open cases, the easy benign TVHs. You know, I think I could probably walk a resident through that. But like the big like fibroid uterus, where patient had like 3,000 abdominal surgeries, like that might be a little bit more difficult for me to do just graduating.
I don't even want to do those, Sarah. So, Vi, how do you feel as a person rising up through it right now?
I was going to say, contrary to Sarah, I do not feel comfortable doing a hysterectomy.
That's okay. You shouldn't.
So, I mean, I'm starting my GYN rotation, so I'm definitely getting more involved in these bigger cases. So I'm noticing just with the continuity, seeing the same case more than once, I'm already picking up a lot more. I'm more primed to pick up this knowledge than I was, say, as a second year. But what concerns me is really not maybe how comfortable I'll feel at the end of fourth year, which is very comforting to know that, like, for example, Sarah, you feel great about where you are with regards to approaching these cases. But what happens when you're a couple months out or even 6 months out? If you go into, say, private practice, or even if you're a generalist, I anticipate your GYN volume will not be nearly as high as it is in residency. It takes time to build that case up. And then when you haven't done a case like this in 6 months or 7 months, the concept of overcoming your rustiness to now dabble in this big case, that is what is more frightening to me than I anticipate, hopefully, that I'll feel great about hysterectomies by the time fourth year ends, because you're in somewhat of a groove. But it's that gap from graduating, which I don't know if there's a safe way to necessarily overcome, unless it's you just get volume or you get fellowship trained.
Yeah, well, I think you touched upon an important subject, which is not somewhere I thought we were going to go tonight. But Dr. Blaber, actually, I think for her grand rounds, is going to be doing the effect of surgical volume on outcomes, right? And nice. There is no doubt, and I did this the other day, I did a TLH a couple weeks ago, and I hadn't done one in probably 6 months, and I was rusty, super rusty. And I consider myself to be a pretty decent surgeon, but it's just been long enough that I was like, right, okay. I had to like actually think about each step, as opposed to just go through the surgery like I used to do. So I think you're absolutely right, Vine. You know, that's me starting at a comfortable level and then not doing it for 6 months. If you're not at the comfortable level and then you haven't done it for 6 months, you know, where do you end up?
Right.
And I think that for in private practice, actually, there's usually pretty good support there, where you know usually you have a senior partner or another partner, and you will operate with them anyway, or they will come operate with you, because it's in their best interest to make sure that you know what you're doing, so there are no complications. Because if you get sued, the whole practice gets sued, and that's not so great, you know. So there's pretty good incentive there. I think where we actually fall down or have fallen down is in academic practice. At least at Stony Brook, I won't speak for other academic practices, where we have not really given that support or oversight to our newer members, which is something that Dr. Blaber and I are actually working on doing. Part of it actually is utilizing our MIS fellows. One of the nice interesting things. There's a program in Nevada, and there's a 2-year MIS fellowship, been around for a long time. The first year you operate with the MIS surgeons, and the second year you mostly get farmed out to all the community people, and you do HIS with them all year. And they love it because they have a skilled assistant. But really, honestly, they know more than the community people do. And so not only do they get to help teach a little bit and whatnot, but they get to see complications. And
it's like a win-win for both sides, I think, for the fellows and the community. Right.
Correct. And of course, they come back to the mothership for like the complicated endo cases, or they're not going to miss out on the cool stuff. But I mean, after you've done a year's worth of laparoscopic hysterectomies that are 200 grams, like you don't need to do that many more of those, right? You want to do like the 900 gram uteruses and the previous surgeries and the endo and stuff. So anyway, we're thinking about doing something like that. Hopefully, using our fellows in some sense and our other MIS faculty, because it's exactly right. I mean, I wouldn't, if I were you, Vi, I wouldn't want to go operate after 6 months and then go do a case, right? And as a division director, I don't want you to do that, right? Right. So it benefits nobody to leave you in that situation. So I do think that, I was actually thinking about it more from the resident training, because we've talked about in the past of splitting the residency into more surgical training, or just giving up and saying, hey, if you want to do, surgery, you need to do a fellowship. But actually, that's a very important point, Vi, about post-surgical training for our generalists, because most people, OBGYNs out there, are just generalists working in private practice. Right. And how do we make sure that, they have the right skills and keep those skills? Right.
Yeah. And
that kind of leads into I think we're going to skip the last topic for this month because we spent a lot of time on this, but is the FLS test, which for the listeners who don't know,
fundamentals of laparoscopic surgery.
Fundamentals of laparoscopic surgery.
And it's really a general surgery test for laparoscopy they've been doing for a number of years. I'm not sure how long. And ACGME has adopted it into to OB now. And actually last year was the first year that had to do it and pass it in order to be able to sit for their written boards this year. All of our residents passed. But I guess my question is, what role does a laparoscopic simulation kind of thing, is that something that maybe everyone should have to do every year if they want to keep their privileges? I mean, I don't know how much the FLS test is actually that great anyway, but something like that. I don't know. What are your thoughts on that?
So the current FLS test, I mean, obviously, I think it was very recently, as you mentioned, rolled out to OBGYN. So there's a lot of kinks that they need to work out. Just there's a written component, and then there's an actual skills component. The written component, unfortunately, doesn't account for the fact that OBGYNs do not deal with the bowel and deal with the same general surgery complications. So the fact that they test you on that is a little bit irrelevant. But from just practicing for FLS, the big difference I've noticed is it just forces you to work on little things. Like, for example, using both your hands, being able to simultaneously move your hands and do different tasks under, somewhat of a constrained environment, which is this box, which is supposed to mimic the port sites and the devices that you normally use. I think that, I don't know what kind of test would be the most beneficial, but I would argue that just mandatory skills training like that could not be harmful. I mean, practically, you'd have to see how much more that would improve someone's basic skill set. Because I think for me, given that I haven't had a ton of laparoscopic surgery to now getting to the next step, FLS has been helpful just to help me learn these basic tasks. But once you learn that, how much will it help you to maintain them? That's an answer that I don't know that, we have answers to yet. But at least from the 0 to the first step, I think there is some benefit. And I think Dr. Blaber actually mentioned this. We did pig dissection lab recently, and she commented that she noticed the now fourth years, their skill set had improved so dramatically just by having to go through the process of completing these tasks for FLS.
I mean, do you think that if everyone, in order to get privileges to do laparoscopic surgery, had to do something like FLS every 2 years, say, I think this could be bad or good, but the kind of marginal surgeons who don't operate that much may just stop operating instead of having to go through this every 2 years. Now it might be bad, maybe as again, if it's okay, you're in the Northeast and you can throw a rock and hit an OBGYN. If you're in the middle of Georgia, it gets a little more difficult.
Just kind of going back to the article
but I don't know.
as well.
What do you think, Sarah?
Our field is changing so much that we understand that at the end of the day, surgery is something that we offer our patients, so we have to keep up our surgical skills. But with the advancement of medicine and other technologies, we have so many other non-invasive ways to treat some of the things that we've treated surgically, that you could argue that in some ways unfair to kind of people to say like you need X number of, well, I guess a test is a little bit different, but to say like, oh, you have to have done like 3 hysts in a year for you to still be able to operate, maybe a little bit unfair, because what if you're a private practice where you are treating patients with medicine more and your population is now growing, and now at the age of, before you were treating more like 20, 30-year-olds, and now they're older, now they're like more 40 and 50, and now they need more hysts. You are now at that stage where, okay, I haven't really done a hyst maybe once every year, and now my population is growing. I've had these options of medical management, and now I have to operate. And to kind of say, okay, now you have to retake all these exams to show that you're a surgeon. It's like, who gets to decide, who gets to operate? It's kind of, I think it's like a fine line. Yeah.
Agreed. That's why it's difficult, right? Yeah.
But just to play devil's advocate, not that I necessarily disagree with anything that you said, Sarah, would that be the worst thing? Because, I mean, as you rightly said, it doesn't seem to influence patient care as much because you have, so let me take that back. So surgery is not as big of a component in treatment as it may have been 5 or 10 years ago.
Right.
So if that's the case, then there is a role for an OBGYN to play in medical management, which could be the entirety of someone's treatment plan. So then if you triage that and say surgery is the next step, to then essentially bump it up to the specialist, I wonder, would that be the worst thing? Because for patients, I would imagine I, as a patient, would absolutely go to a minimally invasive surgeon, even if I loved my OBGYN, just by sheer numbers and how rusty or not rusty they were.
I think that's ideal, as long as you have a specialist to send to.
The surgeon,
correct.
What if that surgeon...
I think the caveat is
aside from what the patient preference would be, it would say like, oh, I actually want to operate and I can operate. Then I think in that sense, like, objectively speaking, having some measure could be nice. It's hard to say, okay, who is going to be the governing body to say who gets to operate and on what level and what is a test? Is it going to be hospital based or is it going to be on a national level? That's one. And I think we have to sense of, generally speaking, national level, is the field itself changing? I agree, because as more specialists and as more minimally invasive surgeons are undergoing fellowship, maybe our field is changing so that, yes, generalists are now going to, anytime they have a surgical case, they're going to start referring them out to the urogynecologist, the minimally invasive, trained people. It's kind of, where is this field heading to? And I think it's kind of the unknown right now, where people are not sure where, because they're definitely old school generalists who literally can do everything and they feel comfortable doing, versus I think newer graduates who just got a residency, say they're generalists, I don't think they feel 100% comfortable doing everything.
I mean, all of that is true. It's funny, when you're talking about who gets to tell me if I can operate or not, it kind of goes back to this very American model, really, of medicine, where I am the doctor and I am king or queen of my domain. How dare you tell me how to practice? Right. And nowhere is that more evident in surgery, but because really, when you're in the operating room, you are the king or queen of your domain, right?
Right.
But that, again, we'll go back to population health, right? That kind of butts against population health, right? Sometimes you could say, as a population, this is better, right? And you say, well, I know my patient best, and I'm the one who's been taking care of her for the last 10 years. So how dare you come in and tell me that what I'm doing is wrong? And I don't know how to overcome that. It's just I've heard that in what you were saying, and it tickled me.
I think actually to go back to what you were saying, Dr. Shapa, I think the more scarier consequences would be what happens when there isn't a specialist around.
Yeah.
So then, we already talk about how there's such limited access to care in places that are very rural, and now are we further worsening that access by now having these extra tiers and things that people have to do. And that I think has a scarier consequence than even taking away privileges in an urban society.
Yeah. I mean, they did this not that long ago with Urogyne, where Urogyne fellowship has existed for a long time, but it really only wasn't until 5 or 6 years ago where it became its own subspecialty, and you could be grandfathered in, but after that you have to do a fellowship in order to be, to get boarded in Urogyne. And eventually it's going to be that if you're not boarded in Urogyne, you can't do any of these Urogyne cases, right? And it's taken, several decades to get there because you have to train all those people before you can even, just disseminate them across the country before you can kind of make that move.
Nope. Yeah,
but I feel like, and maybe I'm wrong, but I feel like we're probably on a similar trajectory with MIS. Right. But it may take another 20 years to get us there. Anyway. All right, we went long enough. Any other thoughts on this subject or the other one?
No, this was a great paper, as you mentioned. We probably should do it for Journal Club.
All right. I'm actually doing Journal Club on October 2nd. I was thinking of doing this one, but I could choose another one if you want to do it. It's fine. Okay. All right. Well, thank you very much, Dr. Umesh and Dr. Kim, for being with me. It's so good to get back together again. It felt like riding a bike. And I look forward to doing a Journal Club for the podcast coming up maybe next week or the week after. So thank the two of you, and thank you everyone for listening, and we'll see you soon.